UroPatient. Tune in and see. Prepare your health for you and me. Knowledge is power. We make it clear every Saturday morning.
Hey, good morning and welcome to the UroPatient podcast. I'm your host, Vic Senese. Glad to have you on board. If you're watching us live, you can see us on YouTube, LinkedIn, Facebook, X, and of course, StreamYard. Also, if you're new to the program, be sure to check out our website at UroPatient.com. Best place to learn more about the show. All of our past episodes, all 106 of them, wow, are there. And our helpful information, all our little handouts for everything that we talk about is available. You can download those to take to your doctor's visit. Well, we got a great show for you today. So here's kind of something that we sometimes as men have to deal with, and that's struggling to urinate. Do you ever feel like you're getting up all night long to urinate, or sometimes the stream is really slow, barely can get it out? I've had patients come in, they can't urinate at all, so they're completely blocked off, and that's never fun. All these things could be signs of BPH, and we've talked about BPH in the past. But I've got a friend of mine who's going to come in and talk to you about. Name is Alex Hughes. He's a nurse practitioner, and his specialty is Aquablation. Now, he does all the prep work, and the doctor does the procedure, but he's the pro on it. So, hey, I'm going to bring him in, and you can check out his information on that right now.
This is a quick video on Aquablation therapy. I'll let it run.
The Hydros robotic system is the next-generation AI-powered robotic platform that delivers Aquablation therapy for benign prostatic hyperplasia. This clinically proven therapy uses real-time ultrasound guidance combined with cystoscopy to provide surgeons with a full detailed view of the anatomy. Developed from a library of real-world Aquablation therapy procedures, First Assist AI identifies critical anatomy on ultrasound to aid the surgeon in designing a patient-specific treatment plan. Through robotic control, the heat-free water jet precisely follows the treatment plan. During every procedure, prostate tissue is accurately removed in an efficient and predictable time frame. The streamlined workflow begins with the insertion of an ultrasound probe, providing the surgeon with a full view of the prostate. The single-use handpiece with integrated cystoscopy allows the surgeon to visualize the anatomy as it is inserted, positioned into the bladder, and docked to the articulating arm. Once the entire prostate is visualized, the surgeon initiates treatment planning. Treatment planning begins by identifying critical anatomy using First Assist AI to develop a plan specific to each patient. Adjustments to the plan can be made to the resection angles and depths under real-time ultrasound. The Verumontanum protection zone is created to help protect sexual function. Robotic-assisted resection removes the desired tissue and avoids the Verumontanum by using a bilateral cut to help preserve ejaculatory function. The surgeon maintains control of the resection throughout the entire procedure. Once water jet resection is complete, the surgeon performs focal bladder neck cautery using a resectoscope to cauterize exposed blood vessels at the bladder neck. The Hydros robotic system is the next-generation AI-powered robotic platform for Aquablation therapy, a clinically proven procedure that provides significant durable symptom relief while preserving sexual function and continence across prostates of all shapes and sizes.
So that's the video that I play for my patients. So like when I do their diagnostic cystotrust and I feel like they're an Aquablation candidate, I have that preloaded on my iPads or my wall boards in the clinic, and I have them watch it. The biggest difference between other resection procedures and this one is you have real-time imaging. So you have an ultrasound wand looking up at the prostate. All the other resection procedures is going solely on the surgeon's experience and tissue changes. So you would resect, and you would see like, okay, I feel like I've gotten enough. But when you have something, and the way that I kind of explain it to my patients is, if you have two battles that are going off in the 1500s, and you have, the Northern Army going against the Southern Army. And, one of the armies has a map of the entire land that the other army is having, they're doing their battle on. You're going to have a much more advantage if you have a map of the landscape. So having the map will actually give the surgeon more detailed view of where the issues are coming. So the issues, meaning the prostatic obstruction potentials. So the other reason why this is important is how fast the actual AquaBeam goes. So that AquaJet is resecting at a speed that's done in like 5 minutes. So it doesn't give the residual tissue from the prostate time to heat up. That's where they were having erection problems with other BPH procedures, is you would sit there and scoop out prostate for, 45 minutes to an hour. The residual tissue around the prostate would heat up, and that's where the erection nerves are. So those are the two biggest technology advances. It's very fast. The procedures, whenever I sign a patient up for an aquablation, they're usually done, and we talk about in the OR. The OR time is about 45 minutes to 50 minutes, depending on the prostate size, which is very fast, meaning you're under anesthesia a lot less time as well. This is a quick review of my BPH care plan pathway.
Hello, everybody. My name is Alex Hughes. I'm the lead nurse practitioner out here at Austin, Texas, here at Austin Urology Institute. I'm going to walk you through our BPH care plan pathway. This is our clinic out here in Austin. This is the patient checking in with reception. This is where they can start giving their insurance cards, insurance verification, and driver's license. After he's been checked in, he will wait in our lobby where we do have BPH and urology reading material. The MA will call him back, walk him through, and the first stop is going to be to the bathroom. We do need a urine sample. The biggest reason is we want to see what his PVR is. So that's post-void residual. This is performed by a bladder scan. So after the patient leaves a urine specimen, we'll do a urinalysis on it to make sure that there's no urinary tract infection. The medical assistant has brought him back to the room. She's performing a bladder scan, as you can see in the video here. This scan takes no longer than 10 to 15 seconds and checks bladder dysfunction. So in our practice, anything above 100 needs to be evaluated. So this patient had around 200 PVR, which shows some severe bladder dysfunction. So the medical assistant will dictate it here on the chart, and then we'll give the patient an IPSS score. The IPSS score is the International Prostate Symptom Score. The scoring sheet is a score from 0 to 35. 0 to 8 is mild, 8 to around 20 is moderate. Anything above 20 is severe symptoms. This patient has checked off that he is severely symptomatic, which is why he is here. He's here for nocturia and dysuria in a weak stream. So taking him down the BPH care plan pathway is the right appropriate thing to do, especially with that PVR of 200. As the patient finishes his IPSS, he will give it to the medical assistant. At a later date, we may do a urocuff test. This is a urine flow measurement. It checks the mils per second on his urine flow. If the patient shows an obstructed urine flow, which he does, which we will review later, he needs a cystoscopy and a transrectal ultrasound. The cystoscopy is done by one of the providers, either APPs or the MD. It's a small bore camera that goes through the penis and looks at the obstruction of the prostate. It takes about 3 minutes, and then we'll need to do a transrectal ultrasound. The ultrasound takes about 2 to 3 minutes on the backside and takes an exact view of the prostate, and that's how we get the volume done. After this, the physician will have everything he needs to do to give the appropriate diagnosis. Very little discomfort, but it is worthwhile, and it does give us a lot of data. So here the provider has all of the information he needs. He has the IPSS score, which is severely symptomatic. He has the Uroflow study that shows obstructed flow. And he has a PVR that's above 200, which shows some severe symptoms. So we'll do a medication trial of alfuzosin or tamsulosin and bring the patient back. This patient's IPSS score has decreased, but it is not perfect, so we can confirm the diagnosis of BPH. The medication would not work if you did not have that diagnosis. So this is when I really start talking about aquablation therapy and a surgical intervention. I review our wall boards and teach them about aqua. After they've done the aqua, we bring them back and do another IPSS score. As you can see, he's scoring a 1, all the way from severe down to mild, and he's extremely happy with the procedure. This is our BPH care plan pathway. Not every patient follows this exact way, but as you can see, the patient is extremely happy with his aqua therapy. Thank you for listening. Hello, everybody.
So these are pictures of my cystoscopies. So whenever I'm scoping the patient and I'm having the patient actually look at the screen and looking at these things, you can see how this would resonate with the patient. Even patients that don't know what healthy tissue looks like can look at these screens and say, okay, that doesn't look like what I would feel like it should look like. And I will actually show them pictures of healthy bladders post-procedurally, and we'll compare it. So, that would be a grade 3 trabeculation on the left, grade 2 in the middle, and that's a big juicy median lobe on the right. So these are my wall boards that I actually utilize to educate my patients. That's the trifold from the Aquablation. So anytime I do a workup and I finish up with the patient, I give them the trifold of the Aquablation. On these wall boards, I will actually draw the trabeculations in the bladder. I will draw the urine left over in the bladder. I will draw the aquajet removing it. And I do this with all of my procedures. I'll do it with the UroLift. I'll draw the clips opening up the prostate. If it's a TURP, I'll draw those kinds of things. All of those things, I will utilize these wall boards because I want the patient to actually understand what's going to be happening. We don't have these in the satellite clinic, so I'm literally turning their IPSS score over and drawing on their IPSS score. I need them to visualize why they're having the issues, and then they can move forward with a procedure that can really help them out. What is recovery like after Aquablation? So we started really heavily doing aquas late 2022. So we have, 2.5 years of experience with Aquablation. This was not exactly how it was in the very beginning. It took us a while to get to these metrics. So potential overnight stay, 90% are going home same day, 1 to 2 days on a catheter, typically done on a Tuesday, and catheters out before the weekend. Avoid strenuous activities and sexual intercourse for a week. How soon will symptoms improve? 2 weeks to 3 months. So I say that the prostatic tissue has remodeling. You may pass blood clots, scabs over 3 months. So one of my patient complaints for Aqua is intermittent dysuria. So like every 10th or 12th pee, they will just have a really sharp burn. And what I tell them is they're actually passing blood clots, microclots, and scabs. Will they keep their sexual function? I compare everything to the other bigger resection procedures. So there's a reason why they're choosing Aqua, and it's really to have the less risk about ejaculatory dysfunction, the least risk of ED, and then the least risk of stress urinary incontinence. I can confidently say I have had goose egg 0 patients have stress urinary incontinence. I've had one patient complain to me that he had a decrease in ejaculate, and we do shim scores for the erections before and after these procedures, and I've had nobody complain of erectile problems after their Aquablation. You will need another surgery at a later date. The prostate will continue to grow. The 5-year data for Aquablation was fantastic at a 1% retreatment rate. 10-year data is coming out in 2027, so we're going to have hard numbers coming out here soon. But I usually tell my patients, treat this as either a 5 to 10 year longevity of the efficacy of Aquablation, and hopefully they get longer. Can I stop taking their medications? Yes. The whole point of this is to get you off of your meds. So stay on your alpha blockers for about 4 weeks. The finasteride has been gone for a while, and then they can stop their alpha blockers. And then they always ask about the catheter, and I say the catheter is really just to keep that prostatic bed open and healed for about 24 to 48 hours and pass any kind of clots or crud that's coming through the bladder. And I compare it to a cast of a broken arm. All about post-op. So the more education you do pre-op, the better your post-op experiences will be. So I talk to them about their hematuria. I kind of joke. I'm like, you could pass a toy car through that catheter bag, and as long as that catheter bag is draining and you're not having abdominal pain, I am happy. And I will tell my patients, send a picture on your portal. We have Athena, so I'm getting pictures from my patients at all times. So I'll get pictures of like a worm, clot coming through the bag. I'm like, that's fine as long as you're draining. I have the hematuria scale on my pre and post-op education material. So in my post-op education material, it talks about all the things that could happen, and when you could call me, when you should call me, what to expect, the healing process, etc. So education to these patients, they want to know what's going on with them and when to worry. So these are my pre and post-op education materials. So again, it goes over the medications, what the medications are used for, catheter complications and how to write those, what to avoid, all of the things. So this was my 2024 data, and I know this because I actually pulled all this data and I went through every one of these patients' charts. So a 72% average decrease in the IPSS score, and 87% of our 96 patients we treated in 2024 remained off of their medications. To give you a comparison scale, average decrease in the IPSS score for dual therapy, saying alpha blockers and your 5-alpha reductase, is a 10-point reduction. So if you're doing singularity therapy, it's like 6 to 8 points with alpha blockers. You add 3 to 4 points with your 5-alpha. If you have an IPSS score of a 30 and you drop the 30 to a 20, you're not doing that patient justice. You need a bigger gun to resect this prostate.
All right. Well, thanks, Alex. That was great. I like that information. Really like the information that he shared on kind of the workup that it's typical for most patients undergoing BPH therapy. Not really complicated stuff, the post-void residuals, ultrasound, painless, the urine flow test, painless, the cystoscopy. Yeah, I mean, we've had some informational talks about cystoscopy, but these new scopes, a lot of these, especially these disposable ones, are really small and flexible and minimal discomfort. Prostate ultrasound, which I've done probably a million of them. Again, people that do a lot of these, minimal discomfort. So all these things are pretty easy to go through. That IPSS, in case you don't know what that's, the International Prostate Symptom Score. So that's just a score that they came up with for how much bothersome you're having from your prostate. It's a subjective score, and that's really matters. We want to make sure you're feeling better. So lots of treatments out there for prostate, a lot of these minimally invasives. My own prejudice after 40 years of being in urology, from working with patients that had the old traditional scrape job called the TUR, the prostate, to some of these more minimally invasive like urolifts, resumes, and these things that are minimally invasive. I think I always seem to see the best results from anything that removes tissues. Aquablation being one of those procedures that is actually removing tissue. So those seem to be better than some of the ones that are coming along newer that leave stents behind or clips behind and things like that. But that's, again, my own opinion. I think that whatever you're looking at, make sure you talk to your urologist, ask him how many of these he's done, because that makes a huge difference. I really like Alex kind of going through all those post-op information too. How long are you going to have a catheter? That's important to know. Catheter's not fun. Most patients don't really like it. So the less time you have it, the better. Things you need to worry about, those that patient education that he handed out, that's key. We have some of that stuff on our website too. So those are all really important things to look into when you're evaluating what you're going to do for your own particular issue. Number one, though, make sure you get something done, because if you wait too long, your bladder can actually start to decompensate. When he was talking about, and he used that fancy word called trabeculation, that just means the muscle is straining so hard, it's getting these big fibrous bands inside the bladder, and you can see it when you look in with the scope. That's not a good thing. It's not like a weightlifter getting stronger muscle. That's losing some muscle tone. The bladder muscle is different than skeletal muscle, so you don't build it up by stretching it out. Anyway, hopefully you enjoyed that. We'll see you all next week on UroPatient.com.
From research updates to daily advice, Vic explains it all simple and precise. No question too small, no topic too wide. We're your urology partner, right by your side. UroPatient, tune in and see. Baby, your health for you and me. Knowledge is power. We make it clear. Every Saturday morning, the podcast is here.